We'll speak a little bit about malformation of cortical development. And first of all, I need to have some disclaimer that are very important. We published this opinion long time ago, and it continues to be true. In some cases, malformation of cortical development will be detected by an astute or lucky ultrasonographist. So remember that they are very difficult to diagnose. Second important disclaimer is that the cases we're presenting here have been diagnosed by very experienced operators with special interest in fetal neurology, also regarding the corpus callosum, and also regarding all the pathologies we are speaking about. Almost 100% of were referral cases. Usually were referred because other CNS anomalies, particularly ventriculomegalia or normal variants. And there is no data that anyone can report on the cases that were not diagnosed during the ultrasound prenatally. Much our knowledge regarding malformation of cortical development is based on what we learn from the MR. Most studies that describe the postnatal appearance of malformations, and there are only very few studies reporting the prenatal identification of MCD either by ultrasound or by MR. Another important thing is since proliferation of neural migration occurs relatively late in pregnancy, in many cases a normal second trimester ultrasound examination does not mean that the fetus has not one of these diseases. And this is why this is the developmental events that occur during the development of the brain and the peak time of occurrence, and you see that neuroproliferation, that is the earliest developmental event related to cortical development, occurs between 2 and 4 months, starts to occur after 2 or 4 months. So if you perform the examination at 22, 23 weeks, in many cases you will see nothing. Another important thing to remember, and this is even difficult for people that are not in the medical profession, but also for us. Fetal brain MR and pediatric brain MR are not the same thing. They use different sequences, different times, and as you can see here, the images that you can obtain from a prenatal ultrasound or a postnatal ultrasound are quite different. In our lecture, we will to speak about which ultrasound findings should raise the suspicion of malformation of cortical development. And another thing that's interesting to speak about is if it is possible to diagnose MCD before the 3rd trimester, early in pregnancy. And I will show you some interesting cases of the last days before the quiz. Now, which ultrasound findings should raise the suspicion of malformation of cortical development? I start 10 years ago showing 1 or 2 images, and each year I have more images to show because there are new things that you can see that are associated with that, but they're quite difficult to observe. I apologize because some of the cases I am showing them year after year because they are not very frequent. Okay, what we look for at 22 weeks, and it was shown also here in previous lectures, also by Daniel and also by Ravi, that if you see very early in pregnancy the presence of sulci, particularly in the convexity, that is something that is abnormal. Sometimes it's difficult to understand that they are there. And if you have a question, what I recommend is to have a little collection of normals of the each week of pregnancy and to put them together. This is the normal sulcation at 22 weeks, and this is an abnormal case. Again, this at 28 weeks, you have a very smooth cortex. At 28 weeks, you should have at least some gyri present. So if you see that there is no gyri, you should suspect that something is wrong. And it's not so important to make a specific diagnosis. I will show you how difficult it is to make a specific diagnosis according to the tables of Barkovich or to whatever. But the important thing that people that are doing screening ultrasound day after day after day, is to recognize, to have the blink that something is wrong. If you have the blink and you understand that something is wrong, you have done more than 90% of the process. After that, it will be easy. You can refer it to a patient, to a specialist, to MRI, to whatever. But you are doing the job by seeing that something goes wrong. Other signs at 31 weeks, you see that the gyri, there's a lot of CSF between the gyri, and they are very broad, and they enter very, very, very profoundly inside the brain. They are very, very clear and should not be so clear. When you have a very smooth or thin cortex, should not be like this. Now this is a case at 18 weeks that you see that the ventricular wall is absolutely abnormal, it's irregular, and also there are abnormal sulci. A few minutes ago, we saw a similar case shown by Ravi. An irregular cortex. You see the cortex is here is regular, but here it's like a saw. Okay, it's dentate, very, very irregular. This is highly suspicious of polymicrogyria. And a lot of time, I have many patients refer because of asymmetric ventricles or asymmetry of the brain. And I usually joke with my patients telling that the normal is the asymmetry. We are asymmetric persons, asymmetric entities. When you have something that is very symmetric in the brain, this is the pathology, and you should think about which pathology is beneath these cases. When you have a communication between the arachnoid space and the left ventricle, is clear pathological. The presence of cortical nodules, as you see here, 1, 2, 3, 4. The presence of subtle callosal findings. Here you see the corpus callosum that have here a small entry. But look, there is something else here. You see there is an abnormal sulcus present that goes exactly with the corpus callosum is, and this is a case suspected of polymicrogyria. And again, look always at the wall of the lateral ventricles. This is very early, at 16 weeks, you see two bumps, 1, 2. This is highly suspected of periventricular nodes and periventricular heterotopia. It is possible to diagnose malformation of cortical development before the third trimester. I show you the last example, but I will show you more of them. We don't like, but as Daniela told you, we don't like this classification, but it's the most complete, and I will show you how complicated this classification is. It is so complicated that the same Berkovich, after 1 year, published a paper, a commentary in the same paper, in the same journal in Brain, called Complication, Bechet's Clarification in Classification. It's very difficult to understand what happened. Eventually we will finish by performing genetic or extra new modern genetics, and they will give us the answers of every one of these malformations of cortical development, because step by step there are more and more genetic conditions, mutation, and variation that produce this kind of disease. Now, this is the old classification that Daniela spoke about. It's from 2007, if I am correct, and the space of malformation due to abnormal neuron and glial proliferation or apoptosis, and we will speak about microcephaly. I'll show a little a case of early diagnosis, but this is the new classification. You are not supposed to read. This is why it's like that. This is the new classification. So for obstetrician, it's impossible. Yes. It's on the, okay, very good. It's on the CD. Okay. Now, what is important to know, and I gave a lecture in Copenhagen about that. When we are trying to diagnose microcephaly, we are fighting a war that has been lost before we start. Why? Because most of the cases of microcephaly develop after delivery. So there is no chance that we will be able to diagnose microcephaly before delivery if the child is born with a normal but low head circumference. So the possibility to diagnose early in pregnancy is very rare, and I am showing what is the problem. These are two patients. One suffered from severe microcephaly that after delivery developed in brain atrophy. It's a condition that now we know the gene, and the other is completely normal. And there is no way to say, without knowing the history, or this a previous history, which one will be sick. But sometimes we may be lucky, as in this case of severe early microcephaly. At 20 weeks, the BPD was 16 weeks, with a lot of other malformations. And this is a case of Neulaxova syndrome that actually is the smallest brain in a human. The same with megalencephaly. Perhaps if you go to an ultrasound unit in any country, or you measure your head circumference, we will show that here, at least for men, 50% of us are macrocephalic. Don't worry, it's okay. But sometimes macrocephaly, megalencephaly may be part of syndromes, as in this case, that at 20 weeks, the head was very macrocephalic with frontal bossing. You can see this in the 3D image. Again, it's an old case, and it turned to be a deletion in chromosome 3q. Something that is more common is abnormal proliferation as part of tuberous sclerosis. Daniela showed us a case. And usually when we make the diagnosis by two ways. Oh, the patient comes late on the second trimester with cardiac rhabdomyomas, or the patient has a history of one of the parents or a child in the family with the tuberous sclerosis. And what will you do in these cases? Refer the patient for an MR. Truly? Yes, because you want to know if the brain is affected or not. But if the MR is normal, it doesn't mean that this brain will be not affected, as Daniela showed us. But sometimes, if you perform a good quality ultrasound, you can see things that the MR will never see. Why the MR will never see? Because the MR performs cuts every 3 or 4 millimeters. This one single tumor or one single finding in the cortex will be quite difficult to see it, and you see it's here. So don't send it too fast to MRI. Perform a good quality ultrasound, and perhaps you will see. Again, since we perform the ultrasound, our lateral resolution is better. The chances to see one are much greater. Again, we are not neuroradiologists. We are not pediatric radiologists. Most of us has never seen a case of tuberous sclerosis. So the chance to know what to look for and how it appears are quite low. Hemimegalencephaly, again, maybe diagnosed in utero. This is, again, old case, 2002. And what you see here is the early abnormal sulcation with agenesis of the corpus callosum. And again, this is the case. This is a comparison with the normal. And we look at the brain, and we study the brain, and we perform MRI of the brain. 3 or 4 senior ultrasonographists in Israel look for this child. No one saw the very small cleft lip, and no one saw the preaxial polydactyly. Why? Because when you see a pathology, your eyes go to the pathology, and generally you forget the rest of the fetus. This is the brain. And this is an interesting case. It's relatively new. What you see here, both hemispheres. In one hemisphere is very abnormal with abnormal sulcation, okay, and the other one has also abnormal sulcation, but is more or less normal. There are peri-interhemispheric cysts, but when I measured the corpus callosum was normal, 26. But I measured the corpus callosum. You should remember, usually it's very easy to measure, to look at the corpus callosum. But when you look at the corpus callosum, you are not looking at the corpus callosum in the true midline. You are a little bit to the right or a little bit to the left. Okay? In this case, the pathology was in one side. So the corpus callosum in the right side was, let's say, normal, 26 millimeter. On the left side was much shorter. Okay? It was only 22 millimeters. Why? Because this side in the pathology was much worse, and perhaps disease was there and didn't let the corpus callosum in one side to develop, or move the corpus callosum a little bit to the side. And again, it's the same case, the case of hemimega. Now, when we speak about migration disorders, what we're speaking about actually is what we're looking for. We're looking for aberration on the sulci and gyri development, or we are looking for the associated hypoplasia or agenesis of the corpus callosum. Most, or let's say many cases of migration disorders will have also some kind of pathology of the corpus callosum. So we look for them. Now, this is the old classification. We used to have three groups: lissencephaly with subcortical band heterotopia spectrum. We have the cobblestone complex, and we had heterotopia. Now everything has changed. And now we are speaking, first of all, of the heterotopias. Why they put it as A? Because the heterotopia is periventricular, so it's at the beginning of migration or even before migration, so they put it in the time of development, and there are lots of different PNH, and this is a case, usually they're diagnosed quite late in pregnancy. The patient was referred to us by Dr. Salel because of asymmetric ventricles, and this is here you see the bumps, a lot of bumps. Okay, it was a case of abnormal in the filamin gene. But we can see them earlier, and you see here this case with two small bumps. In the coronal plane, it's very difficult to see them because you see one by one. In the axial planes, perhaps you see them better. Again, at 21 weeks, the same patient, you see that the border of the lateral ventricles are abnormal. There is asymmetric ventricles. One of the ventricles have a rectangular shape, but are quite different. And eventually, the patient decide to go for an abortion, and a periventricular nodular heterotopia was diagnosed. Okay, if you look in the coronal plane, you see one bump, and you need to be very lucky to understand that something goes wrong here. The heterotopia may be not periventricular, but laminar in the white matter, and this is one of the cases. A fetus, again, with severe malformation, this agenesis of the corpus callosum, the sulcation is abnormal, okay? And this is the pathology of a laminar white matter heterotopia. You see a lot of neurons that stop in their way to the cortex, but this fetus has also polymicrogyria, and for a long period of time it was very difficult to ask, because according to the classifications, you have or heterotopia or polymicrogyria. You don't have heterotopia, polymicrogyria, and laminar. Why? And this is probably because we are looking to the most severe cases of malformation of cortical development that they are never delivered, so Barkovich and Dobbins didn't see these cases, and we saw them. Now the second type of malformation now is what is called the Lees subcortical heterotopia, and the most common disease is the Miller-Dicker lissencephalia, because of deletion in chromosome 17. And here you see in a paper very important paper by Fong et al. In the White Journal, that at 23 weeks there is no parieto-occipital fissure, and at 23 weeks again the Sylvian fissure has not developed, it's very shallow. I have another case to show you. It's a medical legal case that was not diagnosed. The fetus was referred because of borderline ventriculomegalia. The lateral ventricle measured during pregnancy between 9 and 10 millimeters. It's in 98. No one in the world will be able to make the diagnosis. But now, in retrospect, again, you see that there is no development of the Sylvian, and the parieto-occipital fissure is not present. This is how we compare between ultrasound and MR. Again, the issue of a brain that is very symmetric. Okay, you see the sulcation is abnormal, and you see here there's a sulci that should not be present at this time. There's a lot of fluid around the brain. Another case of extreme microcephalia with simplified general pattern. Again, you don't need DMR. We perform DMR to have an image. It's quite old, but in the ultrasound you see that the fetus is severely abnormal, and this is after delivery, the severe microcephaly. The child died very fast. I don't have the case of malformation, presumably due to localized abnormal left radial or tangential transmantle migration. I don't have cases, but I will show you some cases of what is called now a malformation due to abnormal terminal migrations and defects in PL limiting membrane. This is what the cobblestone or lissencephalia type 2, Walker-Barbour, Fukuyama, etc. Those cases may be diagnosed early in pregnancy. Usually they are diseases that are autosomal recessive. And here you have a fetus that comes with ventriculomegalia, severe ventriculomegalia at 15 weeks. In many countries, even in Israel, you see ventriculomegalia. This fetus has severe ventriculomegalia. Let's go on, and we will perform an abortion early in pregnancy without waiting. But in this case, there was also a cataract. You see here the cataract, and the vermis was abnormal. So we suspected that this may be a Walker-Barbour syndrome that is relatively common in Israel. And here we have another case. This is come after an abortion. It's a very religious couple that underwent an abortion because of severe ventriculomegalia, and she came in the second pregnancy, again, recurrent ventriculomegalia. So you need to start to suspect that something is wrong with the family. Okay, and here you see the abnormal brainstem, the abnormal pons, and you see here retinal detachment in both eyes. So it was quite clear that, again, this is a case of Walker-Barbour, that you can reach a diagnosis by studying the POMT1 gene. It's quite easy. Now we'll show you two new cases. This patient was referred, again, very early in pregnancy, at 19 weeks. I saw the patient for the first time, was referred to me because of Professor Ronnie Tepper, that saw that something went wrong in the cerebellum. Although the TCD was normal, there was a communication, something that Gianluigi speak about today. And usually, my idea when I saw this patient is to tell them by telephone, don't worry, we'll be okay, because in our results are even better. So from 100 referrals, the chance that the child will have a problem are 1 to 2%. Most of them are normal. I beg to you to remember that although it should be close, and you don't need to see the communication usually between 90 to 20 weeks, there are cases that the communication may be open and remain open, and you can see that there is a pathology until 28 or 27 weeks. So don't run fast to an abortion, because if you perform abortion in these cases, 50% at least of the cases will be normal, particularly when the fetus has not associated anomalies. This is important to remember. So we saw this patient, and I didn't like the lateral ventricles, and you see that the lateral ventricle is not regular. But look at this. Look at the occipital portion of the brain. Look here. Wait. This is one side of the brain. Now you go to the other side, and you see that it stops like a line. Okay, it stops like a line. So at 90 weeks, it seems to have polymicrogyria. It has or a defect in the PIA, and it have also an irregular lateral ventricle. Should be perhaps PNH, periventricular nodular heterotopia. The cerebellum was not so bad. So look at these images. Okay, this is one side of the brain with the bumpy walls. This is the other side with the apparently PMG. The family went for termination of pregnancy, and the autopsy was performed by Dr. Deborah Kidron, that is the leader perinatal pathologist in Israel. And what we saw is that it was not a single pathology. The whole brain was abnormal with periventricular nodular heterotopia, with heterotopia in the white matter, and also with invasion of the meninges by neurons at here and here. And you see, this is a white matter nodular heterotopia. And the final diagnosis, the final diagnosis was of probably one of the cases I show of a kind of Walker-Barbour. This is another case that shows how difficult it is to reach a diagnosis, and how you need to have a little bit lucky, to be lucky. The patient was referred to us because of left ventricular width of 9.9 millimeters. It's normal, why to see the patient? But he came, so we performed the examination, but the fetus was in breech presentation. The examination was very difficult, but I have the feeling that something is wrong. I was not able to say what. At 31 weeks and 5 days, again, it's in breech. The head circumference was 308, that correspond to 34 weeks, but it's within normal limits. Relative short bones. The left ventricles were normal. Again, difficult examination, relative large head circumference with the dysmorphic frontal horns and third ventricle abnormality. We refer the patient for MR. This is the ultrasound at 28 weeks. What is abnormal? Why I think that something is abnormal? I didn't like the lateral ventricles. I didn't like this echogenesis here. The corpus callosum was apparently normal. A feeling. And this is examination at 33 weeks and 4 days, close to the MR, but after the MR. So the patient come to me back after the MR. I will show you the MR also. And you see that the lateral ventricles are asymmetric. Here, this ventricle is bumpy, have a square shape. But you see here again, if you compare the corpus callosum at 28 weeks and 6 days, and look what happened now. The corpus is difficult to see. It's not morphologically normal. Something went wrong also with the corpus callosum. And we have now, let's say, 6 or 7 cases of apparently normal corpus callosum that during pregnancy something went wrong and the corpus callosum turns from normal to abnormal. Okay, here you have the MR. For the MR, it was very difficult to look at the anterior portion of the corpus callosum. The splenium was not very well developed, and again you see here the square shape of the lateral ventricle, and also the possible presence here you see of a serrated pattern consistent with polymicrogyria. Now, when you put the ultrasound and the MR together, and I should be sincere, I saw rarely the pathology after the MR shows me where to go and to see. And you see that the ultrasound DMR, as Daniela told us, may show very similar images. But the MR show also the polymicrogyria in the contralateral side. Okay, and here again is the same case of invasion of the meninges by neurons. The diagnosis was a malformation of cortical development, PNH with calcifications, PMG, glioneural heterotopias in leptomeninges, and also you have cardiac hypertrophy. Sometimes you perform the ultrasound examination, something is wrong. You don't need to be a luminary to know that this fetus at 17 weeks, something is wrong, and you have the feeling that this is a pathology of cortical development, but you don't reach a definitive diagnosis. Why you don't need a definitive diagnosis? Because the patient underwent dilatation and extraction. There is no PM, and the DNA is too expensive to have tests for DNA without knowing exactly what to look for. But I wanted to show you how you can see an agenesis of the corpus callosum early in pregnancy and 15, 16 weeks. You see that the interhemispheric fissure is continuous. There is not the T sign that Ravi spoke about. And again, you see here the abnormal pericallosal arteries that are quite clear. another important thing, this fetus at 15 weeks, someone can tell me what is present there, what is the pathology? Look at the hands. Okay, it's a skeletal dysplasia, a severe skeletal dysplasia. You see the arms are very short, but when you look at the brain, you see at 15 weeks there are sulci. So the diagnosis is what? Thanatophoric. This is a paper that was published in the White Journal. There are 2 or 3 papers on this case. When you look at skeletal dysplasia, go and look at the brain. If the temporal horns are abnormally developed with sulci, the diagnosis is only thanatophoric dysplasia. And this is another patient with thanatophoric dysplasia. Again, you see the sulci at 17 weeks. Different patient with sulci at 17 weeks, thanatophoric dysplasia. Now, a final word before the conclusion. Last year, there's a paper that was published in the American Journal of Radiology, Early Formative Stages of Human Focal Cortical Gyration Anomalies, Fetal MRI. And I like very much the sentence that I marked, that he wrote, because it is already clear for current clinical practice that MRI is far superior, at least before 24 weeks of gestational age, than ultrasound, we perform our study. Note that there is no citation from where this sentence he took the sentence, and this is what they were able to see and to look at 24 weeks or before 24 weeks by MR. I believe that our images are not worse than these ones. So let's say that the ultrasound and MR, at least before 24 weeks, are at least similar to MR. And something important, all the patients were diagnosed by ultrasound because of some kind of pathology, usually or ventriculomegalia or agenesis of the corpus callosum. Which pitfall we have in diagnosis of malformation of cortical development? As a conclusion, severe hydrocephaly. Well, if you have a patient with severe hydrocephaly, it's very, very difficult to appreciate the cortex, and in many cases, we say this is severe hydrocephaly, we cannot appreciate the cortex, and you miss, as I show in one case, you miss the malformation of cortical development. When you perform an early diagnosis of other malformations, as in the case of thanatophoric dysplasia, this thanatophoric dysplasia is not important what happened in the brain, so you go straight for a termination. So there is an underestimation of the cases of malformation of cortical development. If you perform a very early ultrasound or MR, you may miss some of the cases. And again, another problem that we have every time is problems related to the conservation of the specimens. To perform an autopsy in a fetus that underwent termination by feticide by KCL is very complicated, and there are not too many people in the world that know how to perform this kind of work. Currently available ultrasound and MRI equipment enables very good visualization of the main brain structures, including the cortex formation. MRI advanced sequences add information regarding brain parenchyma organization, and this is Daniela showed us this in the morning, and she will show it now in one of the next lectures. Malformation of cortical development can be diagnosed in utero by neurosonography or MR. Early diagnosis is based on a careful search for anomalies, though these anomalies may be very subtle. The ultrasonographic findings that suggest an early diagnosis of malformation of cortical development are the presence of abnormal overdeveloped sulci in relation to the gestational age, small and abnormal gyri, irregular ventricular margins, symmetric hemispheres, callosal anomalies, and associated findings, particularly cerebellum and the eyes. Thank you very much.